Targeting. Now we move to the problem of targeting, and we will see what are the new features in this field.
Of course, targeting is absolutely crucial. Sometimes you have small lesions or small recurrence where that you can see only by CT. And in these cases, you can easily understand how targeting is crucial in order to avoid also big problems, as in the case shown in the higher part of the monitor, where you can see how it's close that local tumor progression also to the lung, and how under ultrasound is almost impossible to see exactly where the recurrence is. So we performed this treatment under the guidance of virtual navigator system, and that was the result 24 hours later, with a complete coverage of the tumor, and we were very happy with this kind of targeting.
The easiest way to help to put the device inside the patient body is to provide an instrument that fit the requirements for this procedure. In this case, we develop a new ergonomic OLED red probe that allow to perform a biopsy even in a 0-degree angle in order to visualize the target in the middle of the image and easily target. The second problem that we have is not just how to reach the target, but to have also the monitoring of the needle inside the patient body. In order to emphasize the needle position, we are able to overimpose a virtual needle over the real one on the ultrasound image. This can be done, in this case, with the eTrax solution by Civico, in which the sensor, a very miniaturized sensor, is placed on a tip of a stylet. In this case, we have an access to our target where we can put inside or a biopsy device or even perform laser treatment. Unfortunately, this channel is not so big to allow other kind of therapy like microwave or radiofrequency. Also because this tool is in metal and this can be affect the treatment. As you can see from the video, moving the needle outside the patient, we can in advance understand which will be the real trajectory and select the best path to reach the target. A second solution, always from Civico, is called VirtuTrax, and is again an electromagnetic sensor that this time can be coupled with the ablation device, not on the tip, but on its axis. This tool can be used to perform ablation, in this case, drainage, therapeutic delivery, but the most important thing is that this device has to be rigid as much as possible, because the problem is that in this case we are not able to
compensate for a possible deviation of the tip of the needle because we don't see exactly where the tip of the needle is. And so you may trust on a virtual needle without being sure of the exact position of the needle. So the real GPS, that is what we really want, is the one with the sensor as close as possible to the tip of the applicator.
And for this reason, with the collaboration of the hospital service, we developed a prototype of an RF ablation needle and also of a microwave one, in which we are able to place a very, very thin sensor on the needle, far 4 centimeters from the needle tip, guarantee in this way that the bending cannot affect the treatment.
We used this technique. That's again a video. So the tip of the needle is at the point where the green becomes yellow, and we used this in some patients, and it's particularly useful when you have tricky cases like this one where the lesion was quite close to the major vessels, and it was crucial to perform a very precise targeting. I think the video is not going. And so that was the result with the good targeting of the lesion. And again, a particular field in which these kind of tools are extremely useful is when the lesions are completely not detectable with ultrasound. In the experience of the Busto Arsizio Hospital, more than 500 patients were treated with the navigator, and less than 2% of these lesions were missed. And particularly, we didn't have complications related to the guidance method, and major complication in 8 out of 632 ablative sessions. I would like to underline between this patient the subgroup of patients with completely undetectable lesions at ultrasound, and I would like to show you this data that is more than 90% of correct targeting in a patient in which the lesion was not detectable at ultrasound. And probably this data is alone enough to demonstrate how useful can be this kind of technology. You can see all the other data on this slide, but I'd like you to focus particularly on this one.
Treatment planning. This, of course, is not particularly important when you are going to treat a small lesion, but becomes very important when you face with a larger lesion. Because for large lesions, even using sometimes the most modern and most advanced devices for ablation, you cannot be absolutely sure to be able to cover the entire tumor, plus the peripheral safety margin with one single insertion. So in those cases, you need some features to help you understand where to go and where to reinsert the needle when one single introduction does not cover the entire volume. And this was done for years in our experience, just manually, just with our eyes and experience. Now it's no longer like that.
Okay, as Dr. Solbiati said, this is going. And so the aim is to cover the whole tumor with the safety margin. And if you have a large lesion, you have to perform multiple ablation and have to be sure to cover the entire volume. This is generally performed for large lesion, and it's important to have a careful preoperative planning. Moreover, it is crucial to try to avoid critical structures that can be close to the lesion that we want to treat.
To design, we develop the possibility to customize the procedure and give for each procedure the result of the necrotic area based on the experience of the center or from the ablation device datasheet. In this case, we are able, selecting the kind of sensor, the power of the generator, to define a protocol and define which will be the necrotic area that we are going to expect. The software is able after to overlay over the second modality and the ultrasound, which is the expected necrotic area, that is the green ellipse, in order to help in the planning of one or more treatment on the same target.
Again, we use this in several patients, and we found that extremely useful. We use this for plan the procedure and understand before the procedure how many insertions we will need and how to correctly plan the procedure. And then during ablation, as you can see, you can place needles and several times and cover the whole tumor with different ablations. Another problem that this kind of solution can solve is the one of gas formation, Because during ablation, when you have to deal with very big lesion, you have a lot of gas that is forming during the procedure, and thus it's very, very difficult to understand which are the part of the tumor that you have already ablated and which are not yet ablated. So you can trust on virtual navigation and perform the ablation in different several subsequent with the subsequent insertion, and understand, thanks to the navigator, which are the part of the tumor that are not completely treated, and perform another ablation.
Finally, last point is how can we assess the results of ablation, possibly immediately, because the assessment should be done during the procedure, immediately at the end, when the patient is still in the interventional room or in the operative room. If you assess the result very beautifully, but 24 hours later or 48 hours later, and the lesion is not completely treated, or the safety margin is not enough large, this can be a problem, because you have to recall the patient and retreat the patient. And all the people who perform interventional procedures like these treatments know that the local retreatment is always more complex than the initial treatment. So it's crucial to achieve as much as possible with the first treatment and possibly avoid a local retreatment. This is also for the situation of the patient, because you have to explain to the patient that the treatment was not complete and he should undergo a new ablation modality.